The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone, this is Cha or Halo speaking on behalf of UP Med Class 93 webinar team. The UP Med webinar series is an initiative of the University of the Philippines Medical Alumni Society. It delves on important current and emerging medical topics and is targeted for physicians, especially general practitioners, occupational and industrial health MDs, primary care physicians, family and community medicine physicians, and other health workers. Registration is free. We are now using GoToWebinar. If you're encountering problems as you participate, please log out from the session and rejoin again. You may use the join link sent to your email, or you can enter the webinar ID 525-258-051 in the page indicated on the slide or in the GoToWebinar phone app. Due to erratic internet connectivity depending on your area, you may get disconnected during the webinar. If this happens, please restart your session. If you cannot rejoin the meeting room, kindly stream the session at livestream.upm.edu.ph or watch the Facebook Live video on our page. Before we start, here are a few reminders. Your mics are muted throughout the meeting. Use the questions box mainly for questions or comments. The question and answer portion will be held after the lecture and will be facilitated by our moderator, Dr. Anna Bondok. An evaluation sheet will be sent to your emails after the webinar. Please advise that certificates will only be emailed if you have answered the evaluation sheet for the webinar you attended. Certificates for UPMed Webinars 2018 will be sent a month after the webinar you attended was held. Thank you for your patience, and we will now turn over our microphone to Dr. Anna.
Thank you, Cherise. And our time is now 12 noon, exactly. And I'm speaking from the IMS building in UP Manila, Padre Fabra. So today's topic is fever in a child immunized with Dengvaxia vaccine, and this is guidance for care. In this webinar, participants and doctors will gain better guidance on how to care for a child presenting with fever and with a history of being vaccinated with Dengvaxia in school. So let's introduce first our speakers. Our first speaker to my left is Dr. Benjamin, kapangalan ko ito ng anak ko, BJ Sablan Jr. So Dr. BJ completed his medical degree also from the UP College of Medicine, trained in pediatrics at PGH, and is currently also faculty member of the Department of Pediatrics. He's a specialist in ambulatory pediatrics and trained in fellowship at the Albert Einstein Montefiore College of Medicine in Bronx, New York. And we are lucky that Dr. Sablan came back to the Philippines to practice. He has had extensive clinical and research experience in numerous outpatient trials involving vaccinations, tuberculosis, and nutrition. So he is considered the pediatrician's pediatrician because he takes care of lahat po ng anak ng mga doktor. And currently, his present position, Dr. Sablan is the president of the Philippine Ambulatory Pediatric Association and also is an associate professor at the UP College of Medicine. We'll also be joined by Dr. Eva Cochonco de la Paz. And Dr. de la Paz is also another eminent pediatrician of the Philippine General Hospital. She graduated also from UP Med. She took her fellowship abroad in Japan and in the University of Toronto. She was outstanding researcher, professorial chair for excellence. Napakahaba po ng kanyang accomplishments. She would just like us to stick to the present, so let's go. She is the executive director of the National Institute of Health, and she's the section chief of genetics of the Department of Pediatrics here at PGH. So we're also joined by a international pediatrician, Dr. Mutya San Agustin, and she's from UP Class 57, and she's retired from Montefiore. She was a professor, and she's the founding president of the Philippine Ambulatory Pediatric Association. So we are here joined by three eminent pediatricians to give us some guidance on how to treat patients who are vaccinated with Dengvaxia. So Dr. Sablan, would you like to start?
Thank you, Dr. Anna. Should I say Congressman? Okay, so I'm asked this afternoon to talk about fever in a child immunized with Dengvaxia vaccine. And this is a guidance for care for just about any pediatric healthcare provider, which I belong to. I'm a general pediatrician, so the approach I'm going to take for this afternoon's talk will be how does a general pediatric healthcare provider approach a child who has been immunized and who has fever. So if you look at it, Dengvaxia is part of an immunization program or a vaccination program. And for all vaccinations which can be interchangeably termed as immunization, it's a core component of human right, particularly to promote the health of an individual. It's a community and a governmental responsibility. And if you look at the success of vaccination, it has actually prevented an estimated 2.5 million deaths each year. Some of the triumphs of vaccination really have been highlighted by the eradication of smallpox, poliomyelitis, which is actually nearing eradication all over the world. In the Philippines, we have been declared polio-free. And really, every year you see there are a large number of deaths from vaccine-preventable diseases. Particularly in our setting, we see a large number of deaths which have been prevented due to the measles vaccination, which is in place in our country. Also, we have to understand that in vaccine development, before a vaccine comes out in the market, it undergoes a very, very rigorous vaccine development process or research. Basically, you can consider it two phases. The first is the preclinical development, which is carried out in laboratory assays and on animals. It includes identification of the relevant antigens. So antigens will mean, like for our vaccines, diphtheria, pertussis, tetanus, these are the antigens which are identified in the laboratory. It creates a vaccine concept. Basically, the vaccine concept is really, will the antigen elicit a good antibody reaction in the child? It also consists of evaluation of efficacy in test tubes and animals. And basically, it undergoes a process which is called the development of how to manufacture the vaccine through good manufacturing practice standards. This particular preclinical development takes years to develop, after which, if it has been created, then the research goes into what you call a clinical development phase. This is when the vaccine is first tested in humans, and it covers 4 stages over several years. Clinical development is built on rigorous ethical principles of informed consent for volunteers, with an emphasis on safety as well as efficacy. So these are the 2 important aspects of clinical development. The first stage is a small-scale clinical trial which assesses the vaccine's safety in humans, and particularly what immune response it evokes. It's a very, very controlled trial involving very, very few subjects. Once it has been completed, it goes into the second phase, which looks mainly to assess the efficacy of the vaccine against an artificial infection or the clinical disease. And this is a bigger set of samples. The vaccine safety, the side effects, and the immune responses are also studied. So when you're doing vaccine trials, phase 2 will identify what are the side effects which are commonly seen with the administration of the vaccine. Phase 3 is the large-scale study or research of hundreds of subjects across several sites in several different communities or situations. And basically, it is meant to evaluate efficacy under the natural disease conditions of the community, and if the vaccine retains safety and efficacy over a defined period. After which, if you conclude phase 3, the manufacturer is able to apply particularly for the regulatory license to market the product for human use. However, there is a phase 4 after marketing, which is called your post-marketing surveillance. And this stage aims to detect the rare adverse effects as well as to assess the long-term efficacy of vaccines which are being used for humans. So if we chronicle the introduction of vaccines in the Philippines, in 1976, the expanded program of immunization was launched in the Philippines. In 1971, BCG and DPT were actually given, and the tetanus toxoid and the oral polio vaccine. 1982, measles vaccine was introduced. In 1992, universal hepatitis B vaccines were actually introduced in our EPI. In 2010, MMR, the trivalent measles, mumps, rubella were also introduced in our EPI, as well as the pentavalent vaccine. So pentavalent means there are 5 different antigens in the vaccine: the DPT, diphtheria, pertussis, tetanus, hepatitis B, and Hib vaccines. After 2010, you see the introduction of rotavirus, influenza vaccine, and the pneumococcal polysaccharide vaccine for senior citizens. In 2013, we see the introduction of the pneumococcal conjugate vaccine, which is given to children, as well as measles and rubella and tetanus and TB for adolescents. 2014, when we were actually declared polio-free, we introduced the inactivated polio vaccine and DT for school children. In 2015, the HPV vaccine was introduced. And going beyond 2016, we see the introduction of dengue, as well as the Japanese encephalitis vaccines. So basically, we see a lot of vaccines now which are in the market, which are given to the population. Now, the way I'd like to tackle this discussion is to look at the whole vaccination program and cite some vaccines which are known, which are commonly given, particularly the BCG, the hepatitis B vaccine, which is part of the pentavalent vaccine, as well as the pneumococcal vaccine. Okay. When you're looking at vaccines, you're looking at the general welfare of the population. But all vaccines will have adverse events. And it's well known that for BCG, for example, you have adverse events which are generalized disease, because in a young infant where it's given, it can actually cause a generalized serious infection, an abscess, or regional lymphadenitis. In its mildest form, it can actually trigger some site reactions. I just want to make note that the BCG scar is not an adverse event. It's actually a good scar, which will tell us that the BCG vaccine had an uptake in the child or was immunogenic in the child. Particularly for BCG, we have chronic generalized infection, which are severe events. And this has been noted to occur 1 per 230,000 to 640,000 doses of the vaccine given, particularly when it's given in HIV-infected persons or those with severe immune deficiencies. On the milder side, it can cause swelling and abscess, particularly also swollen glands. The pentavalent vaccine, which contains hepatitis B, also is known to have a severe adverse event, particularly anaphylaxis. As we say, even vitamins can have anaphylaxis because these are external agents to the body. So there are really those with allergies which can produce a rare anaphylaxis in patients who are vaccinated. And the mild adverse event, particularly on the injection site, will be pain, redness, swelling, as well as headache and fever. For pneumococcal vaccine, the mild adverse event will be injection site reactions as well as fever. So you will see, and this will occur for most vaccines in the market, that fever seems to be a common reaction to a lot of vaccines. And it's sometimes, you will see in the newer vaccines, there will be less fever, but nonetheless, we still expect fever. Now let's look at fever and let's look at its historical perspective. If you look at fever when Hippocrates wrote that actually fever is believed that it balances the four humors of the body: the blood, the phlegm, I guess this is cough and colds. Black bile is something for GI disturbances. Yellow bile is something for also for digestion. And actually, fever, if you look at it, cook the excess humor to bring back the body back to normal homeostasis. And it has been written that fever is really a mighty engine which brings into the world actually corrects all the enemies of the world. So it's actually a corrective factor. So we should look at fever as a physiologic response. In fact, if there is no fever, there's no physiologic response, we're actually more worried. So sometimes in vaccination, if there is no fever, then we're not sure if it was a good vaccine. Sometimes I tell my patients that you should not be afraid of fever because a fever will actually tell you that the vaccine is doing its role in its immune system generation of antibodies. So definitely, we say that the ability to mount a febrile response to infection has been shown to increase survival rates in many species. It has a positive effect on leukocyte mobility, activation of T lymphocytes, and if you look at it, fever may also inhibit bacterial and viral function. Is it a predictor of illness severity? Okay. Sometimes because we associate fever with infection, we think that fever will imply an infectious illness, and as the infection is actually contained, fever begins to resolve. However, it's very important that we note that the clinical appearance rather than the height of fever is a more powerful predictor of serious illness. So we cannot use the presence or absence of fever as a usual guide to the course of illness. Does it mean that we have a more serious illness when we have fever? Of course, for some infections like pneumococcal, the higher the fever, actually, the more you consider the presence of this particular infection. However, you will see that children in some studies which had life-threatening illness, the underlying medical conditions were actually that the patient was really clinically ill-appearing. So relatively, the clinical appearance rather than the height of the fever is the powerful predictor of a serious illness. Now, why are we concerned with fever? Because fever has systemic effects. Particularly, it can produce heat stress. And in children whom we do a lot of vaccinations, it can result in higher metabolic rates, which will make them more prone to radiant heat loss. So you have an increase in heart rate, an increase in respiratory rate. So it will make them prone to some dehydration. Also, children with chronic illness, particularly cardiovascular or pulmonary disease, with immature or suppressed immune systems or underlying abnormalities, may be more at risk for developing these systemic effects. What's important is really to manage fever. Okay, ideally, if we have in mind the idea that fever is a physiologic response, it's a normal response of the body. The first thing we have to do is to tell the patient that it may have beneficial effects. It shortens the duration of the illness if we're sick. Okay, and really, the more important concern is the uncomfortable child who needs some treatment for fever. Okay, basically, the management of fever will be important because you need to manage or to decrease the metabolic demand of fever. You have to restore nutrients as well as hydration. And you can actually resort to a lot of physical methods like sponging, bathing with tepid water. Cold water is not recommended because it leads to vasoconstriction rather than vasodilatation, which is needed for heat dissipation. So when you have a vasoconstricted child because you with a sponge bath with ice or with something which cools the body, what might happen is the child may actually have an elevation of the core body temperature instead of a lowering of the core body temperature. Also, they say that alcohol is not advised because it can be absorbed through the skin and can lead to toxicity. So basically, what we advise the parent is first we have to calm the patient to tell them that physiologically fever is expected in vaccinations. And we have some pharmacologic agents like paracetamol, which can be recommended for use to alleviate basically the discomfort associated with fever. Just a word of caution that paracetamol is not recommended generally for infants younger than 3 months old without prior consultation with a healthcare provider. Basically, the healthcare provider must assess the presence of a serious infection in such infants. The dose is recommended that is 10 to 15 milligrams per kilogram per dose every 4 to 6 hours. But please take note, it's not given more than 5 doses in a 24-hour period. The maximum daily dose is 75 milligrams per kilogram, up to 4 grams per day for those who are reaching adult weight. And for children, the maximum is 800 milligrams to 1 gram per single dose. Approximately 80% of febrile children who are treated with paracetamol will have a reduction in temperature of 1 to 2 degrees. So paracetamol use does not really result in a child having no fever. It will only reduce the fever in children by 1 to 2 degrees. So if you are seeing a patient with a 39 degrees centigrade fever, then you expect the fever to become 38 and not really go down to the normal temperature. It begins to work in 30 to 60 minutes, and the peak effect is in 3 to 4 hours. So I tell a lot of my patients that you don't expect the fever to disappear in 30 to 60 minutes because your peak effect really occurs after 3 to 4 hours. The duration of action for paracetamol is between 4 to 6 hours. So basically, for a general pediatrician who's addressing fever in a patient who has been vaccinated, for me, these are the take-home points, actually. First, we have to educate every patient about fever at every health supervision visit. If we're going to give a vaccine, we have to tell the patient that part and parcel of an adverse event, which may be expected for every vaccination, is fever. Okay. Children can also get sick, and the first manifestation is fever. So for every patient that we see, for every consult who comes in with fever, we have to educate them and tell them that fever is a physiologic, it's a normal response to an infection, to a vaccination. It is a symptom and not a disease which we have to treat. It's not a disease which is treated with paracetamol. Fever is alleviated by paracetamol. Sometimes now, because we don't use the traditional thermometer, which is mercury, fever determination does not always need to be exact. In fact, what is more important is for the parent to report to us whether they're feeling the child to be warmer than usual. And that actually constitutes a determination or a definition of fever. When we're treating fever, we should treat the child's discomfort and provide comfort rather than treating a specific temperature. It will persist, we know, until the disease process. So when we're giving vaccine, we can tell the patient, the parent, that the vaccination can cause fever for the next 24 hours. And that's part of the process of vaccination. But what's important for those who will be seeing patients who will have fever after a Dengvaxia vaccination, to always rely on the clinical appearance and not on the focus on the fever. The clinical appearance is very, very important for us clinicians in order to determine whether our patient is really sick or not. And we really have to look at it as a fever, not as fever therapy, but rather fever control in a child who will present with fever. That's it. Thank you.
Thanks, Dr. BJ. And Laura Eva will discuss the National NIH statement on immunization and vaccination of Dengvaxia.
Thank you for your kind introduction earlier, Dr. Bodok. I'm glad that BJ already talked about how clinical trials happen before the introduction of new vaccines, as well as a historical perspective on vaccine introduction in the Philippines. Because at this point, what I'd like to discuss is the statement on immunization by the University of the Philippines, Manila, and the National Institutes of Health, which was published in December 14, 2017, 2 weeks after the problems with the dengue vaccine came about. So why a statement on immunization? We were asked many times about this. We did not issue a statement about the dengue vaccine, but rather on immunization. The University of the Philippines, Manila, as well as the National Institutes of Health, believe that immunization is one of the most cost-effective solutions to major global challenges, and vaccination prevents an estimated 2.5 million deaths annually, as already stated by Dr. Sablan in his talk. Deaths from traditional vaccine-preventable diseases such as diphtheria, measles, tetanus, pertussis, and poliomyelitis has fallen from an estimated 0.9 million in 2000 to 0.4 million by 2010. And with the exception of clean water, no other modality prevents more deaths than vaccination. The safety of dengue vaccine in the public health program, the circumstances surrounding this came about when a press statement was released by Sanofi Pasteur regarding the results of the new analysis of the clinical trial data of the dengue vaccine on November 29, 2017. Based on this information, they said that persistent protection against dengue fever was provided by the vaccine among those who had prior infection. However, for those not previously infected by the dengue virus, more cases of severe disease may occur upon a subsequent dengue infection following vaccination. I think by this time, this is already very much clear to the public due to the many Senate hearings that have happened and a lot of public health information campaign, especially from the Department of Health. At that time, the Department of Health placed the dengue vaccination program on hold until further review. The value of routine childhood vaccination, we felt at that time, would be drowned by fear and panic that was happening in the country. So we recognize that the risk that all the media attention to one vaccine will lead to distrust of all other vaccines in the national immunization program. This can result in lower vaccine coverage, affecting not just school-age vaccination, but even infant immunization. Reductions in vaccine coverage may lead to disease outbreaks, such as the 2013 measles outbreak in the country. So the introduction of new vaccines in the expanded immunization program, which Dr. Sablan has previously discussed already, he mentioned that in the past 5 years, the Philippines has introduced several new vaccines in the EPI of the government, namely mumps, rubella, inactivated poliovirus, and pneumococcal conjugate vaccines altogether. The school-based immunization for booster doses of measles, mumps, rubella, and diphtheria tetanus are substantial breakthroughs in ensuring prevention of disease for all Filipino children. So which means that the government tried its best to adapt to the introduction of new vaccines that can help the population in general. But we all know that vaccines have never been free from risk. Hence, decisions on new vaccine introduction require risk-benefit analysis. So this results in tension as public health benefits must be balanced against even remote and theoretical risks. Do Filipinos trust vaccines? In a survey done on vaccine safety and confidence, which this was done, it was published in one of the leading journals in 2016, where they surveyed 67 countries and were able to get about 66,000 individuals to answer a survey. It's a survey on vaccine confidence among the different population groups in the 67 countries. The survey on vaccine safety and confidence showed that 92.7% and 80% of surveyed Filipinos strongly agreed that vaccines are important and safe, respectively. The trust and confidence of Filipinos in the immunization program showed that Filipinos trust our immunization program, and this, we believe, should not be eroded by the experience to one vaccine. We believe that a thorough review of available evidence must therefore be performed in a systematic, feasible, and logical manner prior to introduction. And so our statement ends that the University of the Philippines, Manila, and the National Institutes of Health support the promotion of health and well-being of its citizens through immunization by conducting research that support the implementation of the country's national immunization program, and that we will assist in our capacity to assess any new information on the dengue vaccine as part of our overall efforts in helping the Philippines achieve its immunization goals. And, these are the references for my talk.
Thanks, Dr. Eva. And we are joined by a surprise third speaker. And our surprise third speaker is the chair of the Dengue Executive Task Force created by the DOH. Kailan po na recently?
Late December.
She
just December 26th.
I see. So
But we became official this year.
okay, so she's the chair of the recently created Dengue Investigative Task Force created last December by the DOH, and she's also the eminent chair of the Department of Pediatrics of the UP College of Medicine and the Philippine General Hospital. So she's here to share with us her findings and thoughts on the Dengvaxia issue. Hindi po political, but thoroughly medical and scientific. So as doctors, we can find out what's really going on. It's a huge honor for us to be here today with our chairman. And I'm happy to introduce Dr. Juliet Shaw. So, inayos lang po yung slides ni Doktora. So, while we're waiting for the slides, ito na po. Siguro while we're waiting for the slides, I just wanted to ask, are we ready? Okay, I just wanted to ask Dr. Sablan one question. Yung fever kung yung diniscuss niyo po, is this fever immediately following the vaccination of Dengvaxia? Or as we all know, this Dengvaxia issue, they were vaccinated for 2 years ago. Are we discussing fever immediately following the vaccine? Or fever after 2 years of the Dengvaxia? Because I was, ilinawin lang po natin.
This is actually anytime after the Dengvaxia vaccination. So we all know that vaccines really can cause fever as a side effect. But then now a lot of the panic is on patients who develop fever 1 year after the vaccine, then the question will be, is it related to the Dengvaxia vaccine or not? So I guess what's important for us general pediatricians or general healthcare providers is to look at the clinical appearance. It may or may not be dengue. It may be because of a viral infection. It may be because of a pneumonia. So we have to first be clear for ourselves as to what is the cause of that fever.
Right. Thanks, Dr. Sablan. So, ang diniscuss po ni Doc is fever anytime, initially after the vaccine, 1, 2, 3, 4, 5 years.
Yes.
So basically, we need to be aware of ano ba itsura ng pasyente.
Yeah.
Okay, so are our slides ready? On top? Okay. So again, it's our honor and first time po at ang chairman talagang bigatin po yung podcast natin ngayon. Because I guess the issue is of national importance right now. And ang dami po mga tanong, not only from local government officials, from MHOs, from concerned parents, but even po doctors don't even know the facts anymore. So talaga pong, eto na po talaga, these are the facts, and this is the lady to give them to you. So it's an honor for us to be joined by our professor and chair of the Department of Pediatrics, chair of the Dengue Task Force to investigate the Dengvaxia vaccine, and we are here with Dr. Juliet Shaw Aguilar. Ma'am?
Okay, thank you very much for the opportunity to speak before an audience that can really create an impact among their patients, and if not patients themselves. Before I present the interim report of the Dengue Investigative Task Force, I'd like to probably first look at what is really the burden of dengue disease in not only in the country but in perspective globally. So what are the stats that we're looking at? If you look at the estimates in the global perspective in the year 2016, in the average, this is based on the World Health Organization weekly epidemiological record, there are roughly around 400 million dengue infections, and of which only a fourth of it would be symptomatic. So that's about 100 of these, 100 million. And about 3.3 million will only be severe infections, and about 9,000 will die from dengue, giving us a case fatality rate of 0.009%. So if you look at it in perspective, I place the figures on the right side because this will be important for us to view it in the light of our Philippine statistics. So if you look at 45,000 infections, only 10,000 will be symptomatic because all the 45,000 will probably not be recognized because this is just like any other flu infections. So it's sometimes very difficult for us to say that I have had a dengue infection because it could just be dengue fever. So it could just be any other kind of flu-like presentation. And out of these 10,000, we'd have 1 death and 350 infections. That is in the global perspective. What is it like in the Philippines? In the data of last year, in 2017, out of 10,000 cases that we would have roughly about 55 patients who would die from dengue infection. So it's a whole lot of a very great difference between the world experience and the Philippine experience. We had about 130,000 cases of symptomatic dengue and had about 732 deaths. As a fatality rate of 0.56. While we say that this is still less than 1% compared to our cases of other major infections or major diseases, this is still this is significant in the sense that of our patients dying from dengue, if you look at the figures, it's roughly 60-fold times more for our patients to die compared to the average global patient. So I think this is also something that we as physicians need to think about and act on it. And if I were to share with you the experience, the slide that was actually presented by our USEC Eric Domingo last January 29 amongst a group also of people who were important in the dengue control in the Department of Health. So if you look at the 5-year perspective, you can see a kind of a little bit of a trend that there is a rising fatality rate from the year 2013 on to 2017. From a fatality rate of 0.32, it had gradually risen to 0.56 last year. Although our numbers have dropped in total number of cases to 130,000 versus the year before, in the year before then, in 2015 and 2016, we had over 200,000 cases. We had less patients, but we had relatively more deaths. So I guess this is where we need to focus, and maybe at the end of my talk, we need to take action as physicians. So what are the highlights of our PGH Dengue Investigative Task Force, and probably what would be our recommendations? As you may note, when I presented earlier, these are just interim reports, and therefore nothing is yet final. So before we get into the nitty-gritty part of who was in which classification, I need to make sure that we're all on the same plane by starting off with the definition of terms. When we talk about adverse event following immunization, we're actually referring to any untoward medical occurrence that follows vaccination. This could be any unfavorable or unintended sign, any abnormal laboratory finding, symptom, or disease, and does not necessarily mean a cause and effect relationship with the vaccine. So if you have an adverse event, it may or may not be due to the following the vaccination. It may or may not be due to the vaccine. We actually are following the WHO causality assessment for the evaluation of adverse events following immunization. For after all, we were given the task to evaluate the deaths of the first 14 cases related to Dengvaxia vaccination. So these are actually of using the WHO guidelines, it would fall under one of 4 major categories. And we will, and I will just take you through one of these one by one. So we have the consistent with dengue vaccination, and we have the indeterminate B1 and B2, which I will mention later, coincidental and unclassifiable. Since it's easier for us to strike out the latter 2, so unclassifiable basically means that we didn't have enough information to put them into any one of these other categories. So in other words, the information given to us was inadequate. So we just have to put it under unclassifiable. And coincidental, basically because after the event, usually the observation is within 30 days of vaccination, when you would observe the peak or the high risk of adverse events. We actually observe it for a period of 30 days following the vaccination. Looking at the the clinical records, if we note that it is not in any way related because of the presentation, then we would classify it under coincidental. So the patient could have had another disease, and it could be a virgin case that had happened following the vaccination, but had nothing to do with the vaccine. So we put it under coincidental. And I will show you later on how the whole process will looks like. Indeterminate meaning it could be one of 2, B1 or B2. B1 because basically the event occurred within the period of observation, which is 30 days. So any event that occurs after 30 days will fall and has nothing to do with the vaccine will fall under indeterminate B1. When is it B2? When there is inconsistency. No, it's not beyond the 30 days of development of the adverse event. The things that some of the events that in this history of the patient would say that yes, it's consistent, but there will be others that were not. So it will be under B2. Consistent with vaccination actually falls under one of 4 categories. One of 4. That's A1, A2, A3, and A4. So what are these? A1 would actually refer to a adverse event that is consistent with vaccine-related vaccine product-related reaction. What does it mean? It's a reaction due to the inherent properties of the vaccine, whether it is the active component or other components of the vaccine, and this could be like the preservative or the stabilizer. The A2 will refer to vaccine quality defect related reaction. This will refer to those reactions related to how the product was produced. Like for instance, we're looking at not the components, but we're looking at the devices. For instance, if there is a crack and the patient develops some infection following it, it could still be coming in as a vaccine related reaction. So this is under A2. And A3 will be those reactions related to the errors in immunization. So it could deal with handling, vaccine handling, interruption of the cold chain, for instance. So that's why the patient maybe would not be responding, will not be reacting to, would not be seropositive, for instance, after being given the full dose of vaccination. But this is certainly something that is preventable. And A4 will also include those that are anxiety related. So if suddenly the child develops something because of anxiety, then that will also be marked as related, consistent with vaccination under A4. So we also in the protocol that we follow in the evaluation tool, there is also such a definition called vaccine failure, which is the development of a specific disease being prevented by the vaccine in a person who is appropriately and fully vaccinated. In other words, if the patient should be given 3 doses, was given 3 doses, and there was no response to it, then that would mean one of the 3 criteria has been met. Then number 2, it also takes into account the incubation period of the disease. If it occurs within the period that you would expect, that the vaccine and then following the development of the incubation of the disease that is preventing, then you would say yes, this is consistent, and that you would also consider the 3rd factor will be the normal delay for the protection to be acquired as a result of vaccination. In other words, if the patient develops an adverse event 2 days, 3 days after the vaccination, it would possibly be difficult for us to say it is vaccine failure because the body has not yet been given the chance to develop a protection against it. So this may be questionably, suggestive, but not conclusive of vaccine failure. So all these 3 elements will have to be taken into consideration. So what tools did they use for this evaluation? We, as I said, we use the WHO adverse, and this is the causality assessment for adverse event following immunization. This is actually an international tool that is being used for any kind of vaccine that is, to evaluate any kind of adverse event following immunization. So it's not limited to dengue. So we go through this process. If you can see, you can easily access this in the web. And then there are here, if you look at this portion, here you would already see the A1, 2, 3, 4, B1, 2, C, and the unclassifiable here. So it has this definition, and if you have one particular, if you land on one particular assessment, then there are also suggestions as to what you should do. So it is quite a thorough evaluation tool. As to when this was developed, I'm not quite certain, but this is what's still being currently followed. It's a very organized, scientific way of evaluating an adverse event. The adverse event that was the major adverse event that was being evaluated in our setting would be the deaths. Okay, so we were given the question by the Department of Health. What was the cause of the death? And did these deaths have anything to do with the Dengvaxia? Okay, so what we do is, in using the protocol, you go through a process, 4-step process. You identify first, you give the specifics of whether or not your patient, the details of your patient, and you go through a checklist of questions. Even before you go to the algorithm, it kind of guides you when you say, if you're given a question like, for instance, does clinical examination or laboratory tests on the patient confirm another cause? So it's yes, no, unknown, or not applicable. So you go through all these questions, and then with these questions, after this checklist, you move on to the step 3, where you start off with this with the question here. I think I will give you a bigger picture of this algorithm. Then you go through yes and no kind of procedure, and then after this, you have written here what is your assessment, what category it is, and then you go for, is it A1, A2, A3, A4, or B1, B2, or coincidental, or unclassifiable, and you make the final assessment. So this is the tool that we use. So what are the results? Oh, I forgot. I did not. Anyway, I should have put the enlarged slide earlier. But anyway, can I probably go back? And go back. Okay, I just have to go back to. I thought I had included it. There, here. So I don't know if we can. I have it in another slide, but it's not in this file. But you start off with this particular phrase. Is there a drug? I need help here to read it. If there is strong evidence for another cause. So you see this one, patterns after that. If there's no, out na siya talaga. So it could probably be not related to vaccine. And the second one will say, is there a known causal association with the vaccine? So if it's yes, no, you follow the pattern. Okay. And the other one is the blue one. Is there strong evidence against causal association? And if there's yes and no, then you strike it out already. No? And the last one will be, are there other qualifying factors for classification? The last one here. So you answer it if it's yes or no, just following this algorithm. And then the good thing about this is that it's easy to follow. But on the other hand, I must caution us to say that you probably need to have some practice. Because you need to be somebody doing this should be knowledgeable about the possible disease conditions of the cases beyond dengue, because you need to evaluate the other diseases as well. So in our team, we were composed of a team of 10 with different subspecialties. We had cardiology, we had 2 infectious disease consultant, and then we had 1 allergies immunologist, and GI was me, but we had emergency medicine specialist. We had a neonatologist. We also had a nephrologist. Okay, the geneticist was called in for some because originally we did not include the geneticist because we had not seen the cases. So that was how blinded we are with the cases. We looked at what we should do, define our terms, what tool we should use, and then we said, what was my criteria for collecting the patients? The task force? 1, should be somebody who is not connected with any vaccine, because we did not want to be biased. Any vaccine company, as a matter of fact, we had to strike out 1 because he was with another company, but not with Sanofi. But we were strict because we didn't want to be affected in any way. And the second was someone who has not, and the other one was somebody who was not given Dengvaxia. Because we felt that maybe if once somebody was given the Dengvaxia, maybe a little clouded subconsciously to protect oneself. So we said, no, we were not going to do that. No? We want to be above board, and this is why we continue to say. And yesterday in the Senate hearing, I said that while we were mandated by DOH to do this, we'll categorically say that we are not subservient to the wishes of DOH. That has to be communicated clearly, because I've been getting here and there that because we are mandated by DOH to do this, baka we might favor DOH. And certainly we are an independent group. So that has to be categorically stated. And we are, at this team, we had additionally, we had later invited a geneticist, depending on the cases that we had encountered, and a rheumatologist, and what, and a neurologist. So, and also a hematologist, oncologist. We had asked for 4 more specialists. So, and including our secretariat of composed of our residents, we were a team of 17 who worked on this. No? 17. The process was, we divided into 2 groups because we had a timetable. We had 2 weeks to do all these. So we broke it into 2 groups. So 2 groups, each taking 7 cases, studying them, and then individually first, and then meeting there as a team, and then finally coming to a plenary session. So you can say that each of these cases were kind of studied 3 times over, okay, and even over beyond, when we continue to get, comments or even queries regarding our evaluation. So what are our results? This is the summary slide that is most important. And you probably have seen this yesterday flash in the Senate hearing. Out of the 14 cases that we had, 3 cases were under A1 category. In other words, they were consistent with causal association. And 6 were B1. In other words, just a temporal association, because the events happened within 30 days of vaccination. 3 were coincidental, and 2 unclassifiable. The 2 unclassifiable presented actually with joint pains and seizure, like a stroke in the young. So, but we didn't have any other details of the circumstances surrounding the death. Had a few about what they were experiencing before, but not the immediate circumstances surrounding death. And the 3 coincidental cases were cases of rheumatic heart disease, septic shock, actually presenting with an ear infection, and cardiac arrhythmia. This is the one that we needed the geneticist to help us with. This was actually a patient who was you can see is developmentally delayed and had some flashes, and suddenly presented with almost like a suspected, vagal kind of stimulation reaction. So we thought that maybe that was more of a cardiac phenomenon. And then the 6 B1 were actually 2 cases of leukemia. The 1 case of lupus, 1 congenital heart disease. The heart disease is actually, died of congestive failure. 1 brain infection presenting like almost like encephalitis, query, JAPD, and brain hemorrhage. Actually, this brain hemorrhage was a patient who had a previous history of supposedly having a tumor at the age of 8 months, but it never reappeared and was able to live up to 12 years old. And when the time of around this consultation, the patient had another CT scan that never documented it. So we thought that maybe the tumor was not really a tumor after all. No? But the patient actually presented with pontine hemorrhage. So because of the temporal association of these cases, they need, some of these will need further investigations. And out of the 3 cases of dengue shock syndrome, I'll take you through one of each of these. No? The first case was actually a patient who has had 3 doses of the dengue vaccine, and the reaction occurs after 1.5 months of the 3rd dose, and they presented actually with the typical signs of fever, headache, the clinical symptomatology of dengue, and therefore we thought that this was really a case of dengue. And besides, there was also confirmation that the patient had dengue, because the NS1 antigen was positive. The dengue IgM and IgG, however, were negative. We had expected, hopefully, that since the Dengvaxia was given, that this would have been, at least the IgG would have been positive, but there was none. And this patient died 5 days after the onset of illness. So we thought that this could possibly, the patient could have contracted the wild type dengue vaccine despite the 3 doses, and that we thought that maybe this will actually fall under possibly vaccine failure. We're not yet very categorical because we want to make sure that there is further evaluation before we pin down exactly vaccine failure. So this is what we are hoping to be able to do, and at the Research Institute of Tropical Medicine, because they have been doing PCRs on some of their state studies already, and they have had a few of experiences with during the Zika virus concern. And that we also want to look at the antibodies to the yellow fever and dengue virus. Why yellow fever? Because Dengvaxia is a chimeric vaccine that was created under the backbone of yellow fever vaccine, and therefore we don't know how the reactions will be. So we'd like to just look at this. Why did they choose yellow fever? As far as I gather from the literature, this is because the yellow fever backbone will give very early sustained immunity, plus it's considered to be safe. So these were the reasons why they used the yellow fever backbone for the Dengvaxia. The second case is actually also a case of dengue shock syndrome clinically, who presented 4 days after the first dose of vaccination. Presented with the typical signs of fever, body malaise, and a headache, and was consistent with dengue shock syndrome, and even presented with a documented elevated liver enzymes. 5 days after the onset of illness, the patient died, and there was actually confirmation that there was NS1 antigen, but the antibodies were both negative. Because of the acuteness of the illness, we thought that we were wondering, maybe this patient has been incubating before the patient was given the vaccine. So because it's just 4 days after the first dose, and it's just 1 dose of the vaccine that was given. So because of the unusually acute course of the dengue infection, we thought that the patient could have been incubating the wild type of the dengue vaccine, of the dengue infection, that we would like to go through some further evaluation of this. We could probably go into viral sequencing, that we hope to be able to achieve on top of this tissue analysis. So as we speak now, we continue to open our investigations to other possible tests that will confirm our investigation. What about the third case? The third case has received actually 3 doses of the Dengvaxia, and 1 month after developed the typical signs of and symptoms of dengue and went into shock. The patient died 6 days after the onset with a documented positive NS1 antigen and a positive IgG, but negative for IgM. This actually is the most interesting case because we were thinking if this patient had developed IgG already, then it would have been protected following the 3 doses of the dengue. So this is something that again will possibly be potentially a vaccine failure, or the patient it could be from another cause. Don't know because we know that a second infection is always worse than the first, right? With the natural dengue infection, and that what is being invoked here would be the antibody-dependent enhancement. Was there disease enhancement? We don't know. We cannot categorically say. So this is why we need to see as much information as we can get using viral sequencing, PCR for RNA, and the antibodies to both the yellow and the dengue. So there are a lot of things that we don't know yet for this case. In a study that was done in Nicaragua, they were able to show that antibodies of a certain particular level was associated with it. It didn't have that advantage. So it was like a vaccine that is when diluted to 1:20, up to 1:80, if they're positive, These are the ones at risk. So it's not a very high level of antibody, nor is it a low level, very, very low level of antibody that we're speaking of. So we don't know yet. So this one, we're still learning from, we still have to learn from the experiences in the other countries. So what are the recommended for these cases? For, yeah, okay. So we need actually, while there are 14 cases, we need further investigations for this 9 cases. Of course, the 3 dengue cases will have to go through the tissue examination. We hope that we'll be able to get the PAO to give us some samples of the tissue so that we don't have to exhume the bodies anymore, because it's a poor family, so distraught already at this point. And then we also think that we need to investigate 3 cases of the temporal association. But it is the one with the brain infection, congenital heart disease, and the pontine. And then we also have the one with the cardiac arrhythmia, which, although coincidental, because at the end of with the demise of the patient, the family doesn't know yet what is really the cause of death. So we'd like to go into an autopsy evaluation. And of course, for those who are unclassifiable, it behooves us to even review, if not the clinic, the diagnostic tests were done in the imaging studies, and if possibly the autopsy to at least provide the family some closure regarding the death of their patients. So, so what are our conclusions and our summary of this interim report? Further investigations are needed to clarify the nature of the association with Dengvaxia or the cause of death for the following cases. All 3 cases, 1, 2, and 3, plus the 2 indeterminate cases, 5 and 6, will have to go through some tissue evaluation for polymerase chain reaction, viral sequencing, and even antibodies titer determination to the yellow fever and dengue. And for the one of the B1 indeterminate, 1 coincidental, the D3, the case 13, and the cases 12 and 14, which are unclassifiable, maybe an investigation like the autopsy would suffice. So certainly we do have our limitations. We're not saying that we are the answer to all these questions that we have, because the ideal situation is for us to refer all these evaluation results to the DOH pharmacovigilance team. And the team, they will be looking at if there is a pattern that they can observe, and this is what they call, if there are new signals to, if there's a pattern, for instance, the patient has suddenly developed, after the vaccination, will bump into a door, you think it's only coincidental. But if in the review of the cases that you see, almost every single person would have that kind of history, then you think, oh, maybe nahilo, and then got the subsequent event, no? So these things still have to go through a lot of evaluation. And this is as recommended by the Council of for International Organizations of Medical Sciences Working Group. So only after these further investigations are done can the results be considered final. So in the interim, while we're waiting for all these results to, all these investigations to happen, what do we need to add? How should we address this scare that is happening in the entire country, which I think is really getting very out of control. I think overarching the recommendations will be a call for all that can ensure that if we, as specialist physicians, we can translate the right information to our patients, that there should be clear, specific, and appropriate information that we give to the public on dengue infection. You cannot, even with Dengvaxia vaccination or with the wild-type virus infection, you will not get it unless you are bitten by the mosquito. So we need to make sure that the preventive aspect is taken care of, that we have to clean. We have to be clean. We have to clean up our environment So this is one time that we can do an osoji, if the Japanese would say, you know, the annual cleanup that they do. Huh? So anyway, cleanup of the environment. No? So clinical presentation should be clearly communicated. Many of these cases that we had reviewed didn't even present with fever. They were so scared because they were just given Dengvaxia. So all these, the clinical presentations should be clear. So you have to say you have fever, maybe 2 days to 7 days, headache, rectal pain, or you can have joint pains, all these. No? And in other words, it's still very non-specific. But the rash will usually come much later and usually a signal of that the patient is recovering. And what actions need to be taken if for suspect cases? The government hospitals, there are already some pathways that they are being followed for patients who are suspect cases of dengue. And in PGH, we have additionally placed a pathway for patients who are consulting with the history of Dengvaxia vaccination. So we'd like to look into this particular group of patients as well. So we need to make sure that they need to consult as soon as possible if they are suspicious. Yeah? Then number 2 is again to the health practitioners, those who are in the care of children or patients who are suspect cases of dengue. We need to do a thorough review of our existing treatment guidelines, particularly for fluid management. We need to be adept with the management and always emphasize when you're dealing with dengue, fluid is of the essence. Fluid is very important. So we need to make sure that fluid management is adequately given to our patients. So with that, thank you very much.
Thank you very much, Dr. Rao, for that exhaustive review of the cases, and thank you for sharing with us the interim results. As we know, this is not yet final. We're opening the floor for questions regarding the care of patients with Dengvaxia. So who have fever, who got Dengvaxia vaccine. Okay, this is actually my question, and I asked this earlier. So the question is from Vanessa Marie Velasquez, so from Clara Velasquez, and also from Dr. Mondok earlier. What stage exactly was of vaccine development was Dengvaxia when it was introduced in the Philippines? And I guess when we mean introduced, we mean when it was injected into 800,000 kids. Are we stage 1, stage 2, stage 3, or stage 4?
I think I'm not privy to the protocol and the vaccine development, but I think it was stage 3, phase 3.
Ano po ang phase 3 ulit?
Phase 3 is again, you're testing the safety and efficacy of a vaccine on a bigger sample population, normal population in multi-countries, multi-sites in the natural disease condition. So when you're doing research, you're trying to catch all the possible side effects and adverse reactions. So when you're doing research, kahit na simple rash on the skin has to be reported. And that's particularly in phase 3 when you're doing really close follow-up on a bigger number of population who will be vaccinated. And then they specify what age they will vaccinate.
So thank you. So I guess that means that we are in phase 3 of Dengvaxia, of the Dengvaxia vaccine. So assuming that we're in phase 3, so we as clinicians, we're supposed to report all and any adverse effects that we see among the 800,000 children.
That seems to be the case now with asking all clinicians who see patients who were vaccinated with Dengvaxia who present with fever. That was the protocol which was, I guess this was circulated to us. Those who were actually vaccinated with Dengvaxia with fever, now we will have to really we do a dengue NS1 test and closely follow up all these patients.
Yeah, the DOH has actually given us an algorithm
Yes.
that we follow for. I'm sorry, I did not have. I didn't bring the slide with us. It was actually presented this morning. Grant audit. So anyway, let me just share with you that it has. There's an algorithm that we particularly use for patients who present with into hospital for a suspect case of dengue. And they and if it's dengue, then it goes through you answer a certain form, and then that has to be submitted to H. There's also one side. This is something that we developed in the department. That because of the concern of patients who were given, also made allowances for them. That if you were a case of a patient's pre-given Dengvaxia, even if you did not have clinical suspicion that think that this was clinically dengue, we'd also go through a process to make sure that we did not overlook anything. But certainly all cases presented with fever will have to be investigated. In summary, there will be, if either of these sets of cases, they will be investigated. If they are assessed to be well enough to be managed on outpatient, then they will be managed on outpatient basis after some bloods have been taken. And for those who have not been, for those who are clinically, warranting admission, then they will be admitted. And with these patients, both for those who have been given Dengvaxia and those that have been admitted, and all the other cases who have to be admitted even without Dengvaxia, there will be further tests that will be to look at to establish the effects of the vaccination. So there will be some tissue, some serum specimens obtained. I think with 5 ml of whole blood will be extracted of these patients who were admitted into hospital, suspect cases of dengue, with or without Dengvaxia, plus those who have been given Dengvaxia. These will be the subset of patients who will be given additional tests.
Meron akong algorithm at DOH.
Yes, meron yung algorithm ng DOH for dengue in general. Kami na lang sa PGH, we decided to put in another one for Dengvaxia. But we can easily share it with you because we believe that this is one area that we still also have to do.
There's a question here. Hi, I work for the DepEd. This is from Ms. Ella Cecilia Nalipong-Buit. Siguro po she's a teacher. I'm just assuming na po. Let's say you're a teacher of Dengvaxia vaccinated kids. I think that's her question. When is the best time to refer for management to the health service provider? Well, let's say a Dengvaxia child went to school with a fever of 39 and you're the teacher. What's the next thing that you should do? Her question is, when is the best time to refer the management to the health service provider? Immediately upon the report of fever? Let's say you're a teacher. A child went to the classroom. Nakapanyo po, mataas ang lagnat. Ang alam niyo po, nabigyan ito ng Dengvaxia. What's the next step? And then you mentioned po na assess clinically. Nakatayo pa naman ako, ay humihinga, was able to go to school. But kinapaan niyo po, so no temperature, mainit. What's the next step?
I think the teacher should actually refer immediately to a healthcare provider to assess the patient clinically. The problem is we're still in the phase 3 trial. So when you're in phase 3 trial, you're still establishing causalities, all the adverse effects. So you really want to pick up whether it is related or not related, all the adverse effects, and see if there's a pattern. So when you're a teacher, I think the best thing to do is really refer to a healthcare provider so that the child can be adequately assessed.
And I think the healthcare provider should be knowledgeable about what the government is doing. So the algorithm should really be rolled out. I'm sorry, I knew I had to bring it, but I forgot because I still had some classes in between the conference and our. So I'll give it to you, I mean the organizers, and we can share it with you. I'll first get it from our infectious disease section.
Okay.
Because our pattern here in PGH will be that all the cases will be handled by our fellows. That's how strict we are with data collection, because there's this PIDSAR form. PIDSAR stands for surveillance infectious disease surveillance report, something like that. Philippine infectious disease surveillance. And then we also make another one for the vaccine.
So, Dr. Sablano, assuming ako yung mommy, yung tumawag po si teacher, may lagnat po yung anak nyo. Sa tingin ko po is 39. Eh, alam ko pong nabakunahan ng Dengvaxia. What's the next step?
Okay, so I think.
And then, tinawagan ko si Tedia. So,
Actually,
or let's say, alipin na barangay, tinawagan ko si MHO. Nabakunahan yung anak ko. More than that, what's the next logical step instead of panicking so that they could be guided po? And how worried should I be, assuming I'm a parent or I'm a teacher? Anong level po namin?
Well, actually, I think the DOH naman is doing
So, punta mo sa MHO.
the DOH is doing, I think particularly for NCR Region 4A, because I live in Region 4A, we've been oriented by DOH really on the protocol. When a patient comes in with fever, you have to assess whether you're actually the patient who might have dengue. And if you are actually considering this, then you do they actually said that the PhilHealth will reimburse, will cover the dengue NS1 test, and then DOH will actually cover if there's aside from PhilHealth, if the dengue NS1 test will cost a little more in private hospitals, then the DOH will be covering it. So I think really the best alternative is go to your pediatrician or your MHO.
Yes,
I think most of the difficulties really fever, knowing whether it's dengue or not dengue, correct? So maybe one of the things that I'd like to share is the National Institutes of Health has rolled out dengue kits at the laboratory in Amman. The DOH has already adapted also. So first day of fever, you know it's dengue, it's not dengue. You can even know the serotype of the virus. So this was developed by one of our research faculty, Dr. Raul Destura, and he's an infectious disease specialist. And the DOH has also, he's training different hospitals all over the Philippines in use of this kit.
So it's available.
It's available. Commercially. And the kit can be used either, you can plug it or it's battery operated. It's small as a mom, and that's why it's called a lab in a mom.
Saan mo nabibili yan? Sa Mercury?
Hindi.
Para sa bahay na lang po. Testing na namin.
No, but it's usually so trained people.
So
there's training that they go through. So usually it's purchased by hospitals.
Available po sa mga private and public hospitals.
They can order, and if they are
Much
interested,
faster
they can contact the National
NS1.
Institutes of Health.
I think what we also have to underscore is that dengue, while there's a lot of scare now, if you look at the overall incidence, hindi naman siya ganun kadami compared to other diseases. So we just have to put it in the right perspective, not because you just been given Dengvaxia. Lahat na lang panic tayo. I think we have to maintain composure. Kasi kung nagpapanik tayo, lalo tayo hindi makapag-assess properly. So we have to conclude, yes, we just have that additional information na may Dengvaxia siya, pero you have to look at the clinical course of the patient. Kung talaga, ano ba siya? Is it really dengue or not? No? So I think we should not add on further to the panic that the general public has been reacting to. So even tayo talaga, I think we have, while it's been very, very difficult for us physicians because our credibility is being questioned. No? So I think we really have to make sure that we know the clinical symptomatology of dengue.
There's a very interesting question here from Dr. Mary Christine Castro. And she asks, what factors, I thought this was also interesting, what factors could contribute to the much higher dengue fatality rate in the Philippines compared to the global average? And I think you mentioned that the global average is
The
one. Yeah, case fatality rate. Samantalang dito po is 55 po yung mamamatay.
Yes.
Paano po yun, and what does that mean, and why is it happening? Could there be that there's more serious dengue in the Philippines?
Well, everything is. I don't think it's been studied, but everything is conjecture. Maybe something could be a late recognition, late consultation, late recognition. It's a late consultation on the part of the public, not aware. Late recognition on the part of the doctor. Okay, and inadequate management. So I guess these are about 3 of the possible case reasons. So that's why we say that we have an urge to have a call for all to review natin lang what's the treatment guidelines.
I guess we don't have any more time for more questions. You can send them in, and maybe we could also schedule. How many questions do we have total that we didn't answer? Napakarami po. So, unfortunately, we were just presenting the facts right now, and we were not able to answer that many questions. But definitely, the facts are more than enough for us to know about, and also to make sober clinical decisions. So I would again like to thank Dr. VJ Sablan, Dr. Eva Cuchonco de la Paz, and the chairman of the Dengue Task Force and chairman of Pediatrics, Dr. Juliet Shaw Aguilar. So hopefully we'll have another session on this, because it's really so important right now. And thank you so much. At least now we know the facts, and separating the facts and the science from the hysteria. Yes. So, would you like to give a last message po para kumalma po yung mga anxiety attack po ng mga doktor and mga parents and mga senadores? So,
The University of the Philippines, Manila, and the National Institutes of Health, our statement is, I just wanted to emphasize, is on immunization, because we don't want the present what's going on to eclipse the importance of immunization, and that vaccination, immunization, so many deaths. So it should not be overshadowed by all the hysteria that's happening.
Dr. DJ?
For me, I think as a clinician, what's important is for a child who was given Dengvaxia and who comes in now to our clinic for fever, the first thing we have to do is to really assess clinically the child. Do a good history and physical exam. Look into, there are so many causes of fever. And for us, maybe establish if we're dealing with dengue. If we're dealing with dengue, then we follow the protocol so that we can really do a good surveillance of all of these dengue infections in a dengue vaccinated child. But then what's important for us is to manage the fever of the child. And if it's not dengue, we have to treat the child.
Dr. Ramutya po is requesting a few minutes.
Actually, as an observant, there is one really important thing that I just want to emphasize from my experience being here and hearing about this. I just want to emphasize the fact when people have asked me about the dengue vaccine, I just want to emphasize the fact that the dengue vaccine is not other vaccines that we have been using in the past. And we have heard questions like, well, if the dengue vaccine is an issue right now, does that mean that all the vaccines are the same? It isn't. And I just want to emphasize the fact that all the other vaccines we should not be concerned about. It has been established, its efficacy and its usefulness. So just because there is a panic on the dengue vaccine, there should not be any concern about the other vaccines, and that it should not prevent the parents to be concerned about the other vaccines and be concerned about giving it to their children. Because my concern right now, having observed what's going on, is that the parents will not want their children to be vaccinated at all by all other vaccines. So let us be clear about this. Dengue vaccine is not all the other vaccines, and we should not prevent our children to get all the other vaccines that they really need to have. And I just want to compliment all the other experts who had even a very good presentation, a comprehensive presentation of what we have to know about the situation right now. And I thank you.
Salamat po. Dr. Juliet.
Yeah, I think much has been said by the three ahead of me. I just want to appeal to the public, if they are here listening, that they are not to react with so much anxiety. Just be vigilant, know the process that will be involved, fever, walang fever. And then if you are not sure, let the experts, the medical experts, help you decide. Do not listen to other people who are not really from the medical field. So I think it will help allay the fears of many if we go to the right persons. And then for the right persons, make sure we are the right persons. In other words, if we know, if we can diagnose, we should also be able to treat appropriately.
Thank you po to, people said we should listen to the experts, but we already have 4 DOH secretaries arguing on TV. So, which expert are we going to listen to? It's really hard. And then you mentioned that, I guess, there was a mention that there's a panic. Is there a panic, or is this a legitimate concern? I guess that's something that we need to answer, and I guess that will come out in the various questions. But at least hearing the 4 UP experts is already a big help to parents and clinicians. So, sa inyo pong lahat, nagpapabati po. Please greet all the doctors and MHOs of Vigan Province with their provincial and regional DOH who are undergoing telemedicine training. So, hi. Kumusta po kayo dyan sa Vigan? And so, dito na po tayo. So, thank you for this insightful lecture from our PGH experts, Dr. Sablan, Dr. Cochonco de la Paz, our chairman, and Dr. Ambutia. And we have 431 logged into the GoToWebinar, 182 through the UP Manila live streaming and Facebook Live. So to summarize, I guess our experts have summarized it all for us. And we'd like to hear from you. Kindly answer our survey, which you'll be receiving after the session, so we can assess and improve ourselves. You can also receive your certificate only by answering the survey. Please invite all doctors and colleagues to join this continuing webinar series, like our Facebook page, and subscribe to our mailing list for scheduled updates. And you may also email us for any inquiries. On behalf of the UP Medicine Class of 1993 and the UP Medical Alumni Society, we'd also like to thank all collaborator units, like the UP Manila Information Management Service, the National Telehealth Center, the UP College of Medicine Postgrad Institute of Medicine and Medical Informatics Unit, DOST, the ASCI, and Ms. Charisse Orhalo of the Asian Key Health Information Network. So this is Dr. Bondo, together with Dr. Sablan, Dr. Cochonco de la Paz, and Dr. Aguilar closing this session. And next week, we'll have Dr. Ricky Quintos on February 21. Dr. Quintos used to share my clinic, and he's a good friend, who will give a webinar on spider and varicose veins. Updates in management. So yung mga gusto mag-shorts po, makinig kayo rito. Thank you, and just kidding, okay? This is very serious management. Thank you, and see you po next week.